Hey, afternoon and welcome. It is the THCB gang. It is as usual. We are all gathered here today, and I have a great group on with me who I'm looking forward to sharing the gang with today. I'm Matthew Holt from the Healthcare blog, and gather with me today, I have a fine crack crew. Kim Bellard, regular THCB contributor, Grace Cordovano and Robin Farmanfarmaian, both I put down as patient advocates, but obviously are now both do a whole lot more than that. Mike Magee, medical historian. Mike, by the way, I saw Love and Other Drugs on the TV the other night. So I was thinking about you, the movie that you don't appear in, but you should have been. Right. Dubious paths to selling Viagra. And Marcus Whitney, all the way from Nashville, as his soccer team. So let's go live and let's talk about what we are up to and what we've seen in the last week. So obviously, one thing that we're going to think about is there are a ton of people sitting around in Texas right now who are suffering directly, and it's both a sort of economic, personal, social, and healthcare crisis from essentially lack of infrastructure, or lack of infrastructure that's resilient enough to deal with the new world that we're already in due to global warming. So that's one thing that I think is going to come up. And Kim wrote a bit about some of that stuff this week. So Kim, why don't we start with you and then go around the horn?
Well, I think it's going to find out what it's like to live in a third world country. I mean, the pandemic has caught us flat-footed at every step of the game. We had the leader of our country do an attempted coup. The largest state, the second largest state in the country, which is an energy producer, is now without power for many of its citizens. And just out of today, the life expectancy for Americans has gone down a year in the last year. So we're looking like the third world.
Well, there's an optimist for you. Pretty convincing optimist to me. Grace, what are you looking at? What are you seeing?
So we're still seeing patients and their families that are high risk, unable to secure vaccines. We are seeing reports of more vaccines being secured to increase shipments to states. The American Association for Cancer Research just sent and published a letter to President Biden advocating that across the nation, all patients living with cancer and their loved ones who are their primary caregivers should be prioritized. I can't even believe it that at this point, we still have to state this explicitly, that it hasn't been adopted across the nation. So a lot of work to do on the vaccine administration front.
Yeah, we could get into vaccines and a bit about and what Fauci said about teachers, which I thought was pretty extraordinary. Mike, this week, what have you been noticing?
Well, I think what this week kind of reinforces once again, and Kim was suggesting is that, the argument, it's complicated. We can't understand it. It's complicated. What people need to realize is it's complicated on purpose. By making it complicated, Ted Cruz can go to Cancun while the people in the state freeze. It isn't really that complicated. Most of this is about profit seeking, and it's about the very slim majority at the top maintaining status quo so that they get as much profit out of us as they can. And for the rest of us, we're left attempting to pursue equity, even though we're in the majority, even though we would like a society that actually has good government, that cares for everyone, that shows a sense of solidarity. It's an uphill battle. And the reality is, until you face off the Ted Cruzes of the world, you'll never get there. We got Trump out, that's good. And on Saturday, my wife and I get our first vaccine, so that's good. But it's an uphill battle, and we've got to fight it. That's the only way we're going to win.
Robin, I don't know. Are you currently being medicated as we speak, or are you?
I just got it pulled.
Wow, we're always trying to get Robin on video as being an actual patient, taking over Remicade. But what have you been seeing this week?
So I feel like I'm the rose-colored glasses person. I'm seeing everything is amazing. They're coming out with reports. We're going to have, as many people vaccinated as really want it by the end of the spring or the very beginning of summer. I'm seeing here in Santa Clara, I'm in Palo Alto. Santa Clara has one of those max vaccination sites, and 4,000 people didn't show up to their vaccinations, which is kind of crazy. So we're seeing a little bit more supply than we actually needed just in that one instance, but it is kind of crazy. And so I don't know, I'm seeing by the fall of everything getting back to normal.
Okay, we'll have to discuss whether normal is good or not at some point. Marcus, you've been, I'm sure you've been whilst you've been on, so you've been a bit busy. The fund is officially up and running now, and you haven't given me or Robin a check yet, so we'll hands are out. But so that's what you've been up to.
Yeah. So outside of fundraising, I've just been, tracking what's going on in the markets. Probably the two biggest things to talk about. Bitcoin broke 50K. This week. And so, it just continues to show resiliency. And, the narrative is starting to switch to Bitcoin going from Bitcoin going up to the dollar going down. People are starting to now, equate the value of the dollar in Satoshis, which is sort of, the derivative of a Bitcoin. So that's a big thing. And I think coming downstream from that, there's a lot of analysis about the market. The market is in sort of this nonstop bull run, and no one can quite see the end of the bull run because interest rates are so low. And so capital is looking for places where it can make money, and public and private markets are where it can make money. So there's just sort of more money going in there as the interest rates stay where they are. And then the other thing, healthcare specific, is the newest big SPAC this week was ShareCare. That was announced on Monday with Falcon, which is an Alan Mnuchin based SPAC company. So, ShareCare did have their have sort of an initial doc that went out, and the numbers I think are actually probably a little bit more impressive than people might have been expecting from them. They've been quietly growing a pretty diverse base of revenue across the existing healthcare incumbents, providers, and payers. That's been pretty interesting to see. So I don't think this is going to quite be the Clover situation, but it is interesting that they chose to go SPAC as opposed to going IPO.
I was told SPAC and Bitcoin were not going to be on the final.
So speaking as the guy who had a SIM swap hack and be all scared about that and had all his Bitcoin stolen, I'm actually down. If I just bought back in, I guess with the money that was stolen or whatever, I'd be much richer. So bummer, but it's interesting because those three things are all connected, right, on the financial side. Not the least of which because there's we're one of these massive deficits. We're about to, part of the reason the stock market's still going up is we're about to add another 1.9 trillion or whatever the number is again, and that'll get through a reconciliation the next weeks. And what's going to happen as the healthcare part of that is pretty interesting. And there has actually been some movement on that, which I'll mention. But I think I've got two things to say about the SPACs and the stock market and Bitcoin all this week. One is you didn't mention the Owlet SPAC, which is quite spectacular in that their project, it's got, for a public company or about to be public company, the best up and to the right exponential curve I've ever seen. They made $45 million in revenue last year, and they're going to make $1 billion in revenue in 5 years. It's going to be an all chart by becoming the platform for all babies, everything, everywhere. The other thing which, kind of quietly slipped in there, no one's really noticed, is that a couple of senators, including Tim Kaine, former vice presidential candidate, introduced the public option into the Senate, which, don't forget, was in Biden's overall plan or his platform. And, the guy's the president and he has majority of the Senate and majority of the House. So when you say you're going to do something, perhaps you might actually do it. I know we'll see about whether it can come to reconciliation, whether you'll get 50 votes among Democrats for it. I mean, who knows? But, that's a potential change, which may or may not be part of the big reconciliation stimulus package that comes. Having said all that, I'd like to ask us a big question about that, because I thought there was a great article in Politico this morning written by Joanne Kennan. I think it's Kennan or maybe Keenan. I may have pronounced the name wrong. She basically did a big study of all the things that have gone wrong in the pandemic, and essentially said this was, as many of us have said over the months, a great, not a great. This is a perfect way to uncover all the problems in the U.S. healthcare system. And she says there are 5 big things that we should do. And I think they were, very reasonable. One of them is to sort of boost up the public health service, get more people involved, talk about a public health call, which is kind of happening. One is to sort of de-siloize the data in public health between labs and states and governments and hospitals. One of them is to reintroduce primary care as the center of healthcare, which I think is fair enough. You could argue that's that has a connection with sort of increasing value-based care or getting us away from fee-for-service. Another one's to tackle racial and social disparities because they've been obviously completely exposed by COVID. And the final one, as I forgot the last one, is to prepare for the mental health tsunami that's coming. So you can argue that some of that is kind of being done, but would it be reasonable to suspect that given we've had a presidential campaign, given we have now a party in charge that likes doing government stuff, that we should have seen a bigger proposal coming from the White House, from think tanks, from somewhere to kind of do all of that, given we're now a year into COVID? Or am I being crazy?
What I would say is that we're not entirely sure what we're doing yet. That's why you're not seeing the master plan come out. You're right that Mike Bennett and Tim Kaine's Medicare X did resurface today in the Washington Post. And so you could attach some dollars to that. But at the same time, we're really not yet certain what we want to do structurally. So for example, when people say we need to build up primary care and we need to build up our public health system, what exactly are they talking about? For example, we tried to get needles into arms in a large way with this pandemic vaccination. Is the problem we're having a healthcare problem, or is that we cannot execute on the local community level? Because when we did the polio vaccines in 1950s, that relied on a community-based response capability. So what exactly is missing here? Certainly not the science. We got the science. We delivered all of these different types of amazing vaccines. We ran into problems in figuring out how to reach the people equitably and how to do it quickly. So I think, Matthew, until we really decide what we want to build in terms of a real functional system and the role for primary care doctors, the role for pharmacists, the roles for public health people, you're not going to see a plan come forward with dollars attached to it.
I'll go to you in a second, Kim. My question is, I mean, no doubt, and Jeff Goldsmith was on THCB again a couple of weeks back saying, the vaccination campaign will suck the oxygen out of the room for everything else. And no doubt you've got to get the vaccines done because the whole economy is based on that. Forget the healthcare system, right? Until we can go back to normal. As Robin says, we'll go back to normal so that me and her can meet in some fancy San Francisco party. Well, Robin will be at the party and I'll be like outside, but anyway. But until that happens, I get that but I mean, haven't we had enough time to see these? I mean, these problems have been, we've been well aware of them since the summer, right? If not before, that it was happening, the disease was, being visited inequitably on poorer minorities and others and elder people. We had the problems with the nursing homes. We had the problems with knowing that the primary care folks didn't have enough money because they were being paid fee for service. It's not like we haven't been talking about this stuff for 9 months. I just sort of thought somebody would have come up with something more comprehensive rather than just ignoring it. And I'm fearing that if we just say, okay, we're just going to do vaccines and get that fixed, and that'll be all the energy, and then we'll be done, and then it'll be until the midterms, and we'll never actually get anything else. We won't have made use of the crisis. Kim.
We've never met a crisis that we couldn't kick down the road a while. I keep, the American College of Engineers, or whatever they're called, has given our infrastructure, roads, bridges, dams, water treatment plants, Ds for the last 10 years. Some of them are going to fail and going to fail catastrophically, and yet we do not invest in them. So are we going to do something hard, like figure out primary care doctors should get paid more and specialists should get paid less? I don't think so. And until the world comes crashing down, we're not prepared to take on those hard challenges.
Yeah, I have to jump in and say, I'm really struggling here from the patient and care partner perspective, because none of these issues with the rollout are a surprise. People have been struggling with these. Once you have a chronic illness, you have a life-limiting, life-altering diagnosis of disability, you're in it. You're in it for the rest of your life. And you could have asked any patient, here's something I'll suggest. We need to have these people, these patients, their loved ones on these task forces, on these leadership councils, on the decision-making teams, because they know these barriers and they know how to hack them and make them work. What the solutions are, whether they're an easy to fix solution or something more sophisticated. We haven't been doing that. You have to follow the money here. When you look at public health and you look at the reality prior to the pandemic, when you look at, we can talk about de-siloing the data. Is that really happening? That's going to impact people's bottom lines. And they're hiding behind well, we need to protect patients' privacy. Meanwhile, this is business as usual under all healthcare business practices. That the patient's data is sold, aggregated, de-identified. Most people don't know that. Primary care, of course, great idea. Are we funding that, and are we reimbursing? And it all comes to the policies for reimbursement. Telehealth went through the roof. Patients have wanted that forever. The reimbursement finally came to where it needed to be to make it a reality. So I'm not holding my breath that someone's going to come and wave a wand here and make this all better magically. I really do feel that what we need to be is chipping away from the bottom up and teaching people how to navigate and survive. And until we meet clinical needs and real world needs, such as addressing disparities and equities, we're not going to make any progress.
Well, you're a bunch of optimists. Can you rescue?
Sorry, I'm not the optimist here, guys.
No,
We're needed.
I understand it's tough. Robin, be optimistic for me here.
So what I'm hearing, it feels like we're trying to come up with a solution for almost a single payer. We have to remember this is more than $3.8 trillion industry now, over 330 million Americans. This is not one problem. This is thousands of problems. And so one of the things that just was blaringly obvious to me today, because I got my Remicade IV treatment. So Remicade, I get it for $600 a vial, and I have to take 2 vials. It's based on my weight. At Stanford, they're charging $14,700 a vial. And men, my nurse has one patient who needs 9 vials. So his Remicade treatment 8 times a year costs $125,000 if they were trying to get it at a hospital. And for me, it costs $2,000 or less than, 8 times a year, $16,000 for the year versus $125,000 once. So this one thing, and that law just passed, the transparency laws. So you can go onto provider websites. I downloaded a huge Excel file out of Stanford, and I know what they charge now for most things. That's going to be more of a marketing campaign. That's going to be more of patients. You need to step up and take care of your healthcare the same way you take care of your spouse, your children, your house, your mortgage, your taxes, and your job, right? And bringing the patients up, looking those kinds of things up and saying, hey, I'm not going to do that because my copay will be a lot cheaper if I get it through option care.
So you're arguing for a more bottoms-up approach, and I don't think anyone would disagree that creating a more transparency into sort of some of the really egregious stuff, like how much hospitals are charging and how much the extra facility fees are and that kind of stuff, is a bad thing. I mean, on the other hand, I don't know if there's enough. We have enough of the healthcare system, in my view, that happens when people can't really make those decisions. It's not a regular drumbeat thing, or people who are struggling even to get access to care. So I'm not, I think it goes both ways. I'd argue that we do need, yes, we're not likely to have one magic solution happen. But I was hoping for, even if they're incremental solutions, as the ACA has been, I was hoping for a bigger plan of more incremental things to deal with what the virus, the pandemic's exposed, as opposed to essentially what's in the Biden plan, which is to expand Medicare for Medicare option, public option, and you expand Medicare to 65, and you sort of deal with the 2.5 million people who are left out of the Medicaid expansion. That's all sort of papering over the cracks of stuff that was, around before we got to the pandemic. And all the stuff that we talk about with public health and the way that we're paying doctors and the way we're not using primary care efficiently. let alone the problems with vaccine rollout. I haven't seen much about that other than, very, very tactical attempts to get the vaccine rollout bumped up, which seems to be working. Although I would also add that I was a bit scared when Fauci said that we can't get 3 million teachers vaccinated by the end of the summer, because we are vaccinating 1.5 million people a week. And I know there are a lot of, sick people who are required and frontline workers who are required, but I was hopeful the teachers will be on there, because if we don't get the schools back working, that's a big part of the economy which isn't working.
In California, they are prioritized. So teachers are, all educators are supposed to be able to get the vaccine starting in March here in California.
Robin, do you know why 4,000 people didn't show up for their vaccinations? Do you have any idea what's going on?
They're saying it might be a lot of people making double appointments. They're making appointments here and they're making appointments there. And, there's also people, plans change, right? Maybe you make an appointment, you're like, you know what, I'm just going to do it in a couple of weeks. I don't feel good today. Or, the kids are being brats. I don't want to go, so there are those kinds of things. And it's probably that's what they're thinking it is.
4,000 out of how many?
They didn't give the total number that they gave over the weekend. 4,000 out of
100,000, not so much, but it's 4,000 out of 8,000. That's a big deal.
They used them all up. So they realized that they had too much. And so they put out this huge campaign, and thousands of people went down to Santa Clara and got their vaccine. So, they didn't waste any shots.
Again, one way to think about this is to not think about it as healthcare. Just think about it as a well-run municipal government. If you were mayor and you had this challenge, would you actually set up a complex information system where there are inequities in terms of access to the internet, and where older people aren't going to be able to compete with younger people? Or would you simply say, look, our schoolhouse isn't being used on Saturday and Sunday, we're going to open it up. And you know what? We have to give these injections, but maybe we don't have the manpower. But you know what? We're going to ask that any parents of students who are doctors or nurses or pharmacists or EMTs to give up Saturday and Sunday and come in and help us out, and let's get these injections taken care of. And you maybe have to wait a little bit in line, but we're going to get 3,000 people done on Saturday and 3,000 people done on Sunday. And that's all the messaging. That's it. No, instead of doing it that way, we come up with the most complicated matching systems we can figure out. We have theoretical equity that is so exclusive that it ends up being prejudicial against the very people who are most at risk. So, you got to ask yourself, well, are these people just so ignorant, these people with tremendous advanced degrees, that they didn't know that this would be the outcome? Or is this simply part of the way you support an existing career ladder, where everybody is interdependent with everybody else, where the end game is to get a good study, not really to get people injected and safe ahead of variant strains? So what I'm saying is these things don't just happen. If you scratch just a little under the surface, it's about power, it's about my job security, and it's about the money flow. And that's a sad truth. And so, you got to wrest back control over your own municipality. I mean, because otherwise we end up pawns in this thing. It's kind of silly the way it's been run. I see this in Rhode Island, by the way. In Rhode Island, we've got, I'm on the advisory board, even though I don't live in that state. And we have this one mayor who took it into her own hands. She had one of the most vulnerable populations in the whole state. And she just opened the schoolhouses on the weekends, and people came pouring in, and she made sure she was at every session she attended, just like it was 1950. And people turned out in droves, and now her people are way ahead of the pack. So.
Yeah, I mean, there's a lot of lessons that we need to learn, and the question is whether they can get learned in the current environment is another one. All right, so I think we'll as you've all depressed me, and we're not going to have a big solution for all of the 5 or 7 different problems that were analysed in Politico this morning, and we're not even sure we can get the vaccinations done. Although, I think it's going to. I was actually in was a Safeway just up here in Lake Tahoe, and I heard someone say that they had some spare vaccines. I just heard somebody. I thought about breaking it down, but I realized I wasn't quite in the 1B category yet. I'm still the behind the screen guy, not quite old enough. But it seems to me that that should happen. I am very worried about the school teachers. I was very worried about Fauci saying that issue around that the teachers can't get done, because if we can do 1.5 million a week, we should take priorities to get the school teachers done and the educators. It may be happening, Robin, and maybe some of them are going to refuse it. But again, that's to me the most crucial thing around getting kids back into school and getting the equity around, especially public schools, and getting the equity around getting their parents the ability to go out and work and do the stuff they haven't been able to do for the last year. So that's a key thing. But then, so let's move on and touch on some of the other stuff. So Marcus brought some of this stuff up, so I'd like you, Marcus, to dive into it a bit more. Let's talk a bit about the exit strategy for some of these private digital health companies. I know you're in the other end and you're investing, Marcus. But we've seen in the last couple of weeks some semi-odd sort of strategies. We've seen Signify Health, which went IPO very successfully, which is a mix of kind of a home care company plus a bundle payments company. Both of them, by the way, owned by one venture capital, big private equity fund, which put them together. And I hate to tell you this, but the name of the guy who runs the venture capital fund is Matthew Holt. So a couple of people emailed me and said, "Didn't realize you were that big an investor." And I went, I'm very jealous of that guy. But we've also seen, a number of these SPACs go out. Let's talk a bit about, the three which you mentioned. One is Owlet, which is just announced is going to go out. One is ShareCare, which looks like maybe might be a real business. And then the one we mentioned earlier before we came online, which is Clover, which went out a few weeks ago, and it's been kind of kind of attacked by short sellers as to what it is. So I guess the big picture question is, there's a lot of money around, there's a lot of liquidity, and people want to get out. What do you think, Marcus, the sort of viable future of these kinds of businesses is, in the way going out via a SPAC? Do you think it makes any difference? And the valuations that we've seen, which are 5, 10, 15, 30 times revenue, seem to be nuts by any other criteria, but they don't seem to have collapsed yet. So give me a sense about where you think that part of the market is.
Yeah, I don't think we've even seen a full 90 days of SPACs yet. So we haven't really gotten to the point where they've had to actually do quarterly reporting yet. Look, this is the public stock market. These are equities. These are operating companies that have to report. And they have to justify PE ratios, and some of them will be able to do it, and many of them are not going to be able to do it. And they've used this vehicle as a liquidity event for existing investors and as a way to raise capital in the public markets, because the public markets are now a place where you can get alpha, right? You can get yield, and a lot of it is because of retail investing, social media, and a lot of other phenomena, right? And I'm not blaming it on social media or retail investors. I'm just saying, like, these new agents that are at play, are creating new phenomena that we haven't seen before. We've never seen a semi quasi organized group of retail investors be able to execute a short squeeze, right? That's a first. It's never happened before. One large fund against another doing a short squeeze, sure. But like sort of an organization that is community based across Discord and Reddit, we've never really seen that before, where those people have the tools to really do it. So I think it's too early to tell, but generally speaking, we should just all remember these are public markets where these companies will have to do quarterly disclosures. Yes, the SPAC is a way to get to the public markets without quite the level of disclosure and rigor that you would have to go through in an IPO. But eventually you got to justify the valuations. Eventually you got to face the Wall Street analysts, right? And we just haven't gotten there yet. So it's good. I think it's going to be interesting 3 months from now to have this conversation and look at the valuations today versus 3 months from now.
But then again, you have seen, several of these public companies have been out there still not making a profit, right? And go back to Teladoc, Phreesia, some of these other ones. Some of them are getting closer, but you're still, there's still a massive appetite in the public markets to invest in what look like new sector companies, which could potentially take over a big part of a sector and don't have to be profitable for a while. Now, the greatest example of this, of course, going back to the last dot-com boom, was a small Seattle bookseller called Amazon, right? Which I don't think ever made a profit. If they ever did, they hit it pretty well until eventually they couldn't hit it anymore. So, there's a question as to whether there's appetite, in the private and big public, investors for that kind of patience, and whether that some of these companies might really make a big difference. And then, you've got obviously the ones I mentioned. You also got sort of Oscar coming out soon, and then you've got a lot of investment in similar kinds of activities from the big healthcare companies, particularly Optum.
Yep.
So anyway, Robin, you're nodding away. Do you want to dive in here?
No, I mean, I like to watch Optum. I definitely keep my eyes on Humana, CMS, United, and of course Optum, which is owned by United. And so my ears always perk up when I see that.
My point there is that, we're kind of, and it's kind of the inverse of the thing I was saying about, is there a policy change? Many of these companies, so many of them are kind of helping, if you look at ShareCare, which I know decently well, actually launched the Health 2.0 when I was running it way back when. It took them a long time, and they've been basically helping, primarily plans, and they just bought a deal to get into, they bought a company called, did they buy Care.ai or did they buy Doc.ai? They bought an AI. Doc. I keep on getting it wrong. I don't know what either one of those two companies do. I can't understand it, but that's by the by. But to get an Anthem, and there are people who are talking about, do you now have a set of providers who are basically providing, rolling up all the different types of digital health things, right? And so ShareCare is definitely that business. They bought an old world disease management company, Healthways. Well, they got sort of given it basically by the company that had silver sneakers. So there's a lot of stuff going there, and I'm kind of wondering, and maybe I can come to you, Grace, and you, Marcus, about this. Maybe Kim, as to what is there enough appetite there to build an infrastructure the way that Amazon did, that in 10 years' time rather than 3 months' time, we might see a very different healthcare system, the way that retail changed dramatically from 2003, 4, 5 to the early part of the last decade.
I guess I just want to jump in with a question. We started talking about the different things that really need to be in place, citing the article from earlier. And we talked about the role of public health and data and PCPs and tackling inequities and racial disparities, mental health. Are any of these companies that we're talking about right now really getting into the crux of also addressing these real world issues?
Yeah. So as Matthew intimated, ShareCare is sort of a conglomerate of digital health strategies. And so they are, because they're kind of a little bit of everything. When you go through the deck and you see all the different stuff they're doing, it's like they're doing a little bit of everything, right? They're not like an Oak Street where it's pretty clear what they're doing, right? Or a One Medical. I think, Matthew, to answer your question, the answer is yes. And I do hope that these companies can continue to hang in there and be funded long enough. But I was just having a conversation with my partner around this as we're trying to fine tune our theme. And the reality is that healthcare does not move fast, that it is an evolution and it is a process. And so it will, there's not going to be like a Clubhouse of healthcare, right? There's not going to be a Medicare Advantage plan that's going to grow as fast as Clubhouse did. You know what I mean? In terms of their members that are engaging.
They're not going to have 3 million people in a week or whatever.
Yeah, right. Exactly. That's just not apples to apples, right? But that doesn't mean that we aren't at a point now, especially post COVID-19, where there's enough motivation around Medicare Advantage and direct contracting and alternative payment models and focusing on the PCP, where there's enough innovation that, and by the way, these companies relative to the rest of the stock market are not very big. Like an $8 billion market cap is just not that big on the stock market. I think we just need to kind of keep that in frame too. ShareCare, I think, was a $3.9 billion merger. So none of these innovative healthcare companies are even that big. There's Optum, there's UNH Optum. That's a completely different animal. But but most of the companies we're talking about are generally small cap companies. So the fact that they're even on the public markets and building out these things and starting to tap into these areas, Grace, that you talked about, I think is great. I think it's great. I think we do want more of them. We need to be rooting for these companies to be successful, because if you don't have them, I don't know what you have. You have a bunch of small venture-backed things, and that ain't going to do anything. You need these scalable, publicly traded companies that are viable enough to do business with some of the largest employers in the country, right? So we need them to do well.
I just add to Kim in a second. I just add a couple of things. One is of the things that I brought up earlier. Clearly, there is an attempt to do something about primary care, which is, Marcus mentioned Oak Street, and you got IORA, and there's a bunch of money heading into primary care companies. That's splitting in many ways, whether it's people like Crossover doing it with Amazon, Medicare Advantage, people specializing in Medicare Advantage, or this incredible amount of venture funding, not really gone into the public markets yet, with the exception perhaps of One Medical, for kind of slicing off different pieces of primary care and making it more consumer user friendly, right? So you got One Medical, but a company called Eden Health got funded on 100 million this morning, which is trying to do a good online, offline primary care play aimed at medium-sized employers. So that's just one. And you've got Tia for women and Maven aimed at mums and kids as well. So there's a ton in particular areas. I would say there's a lot of money being thrown at the data de-siloing piece. You can, in fact, there was a whole bunch of hospitals who get grouped together, big hospital systems, to sell their own data. Or a company called is it called Truvita? I may have got the name wrong. It was close enough to Truvia.
I think Truvia. Yeah, that's what I thought it was.
Truvia is the sugar, the fake sugar. And then Truvita, I think, is the new company, but I may have got it wrong. But it's basically another, and a lot of people have been selling data for a long time. I'm not sure, but I mean, the idea is we're seeing a lot of interest, and you are hearing much more about FHIR and moving data around, and Apple's now got on health records got a whole bunch of data you can get from mobile. So, I mean, things are different than they were 10 years ago. They're not perfect by any means, but we're kind of getting there. In fact, Bob Wachter, who's commented a lot about this, was on a podcast with my old Health 2.0 colleague Indu Sabaya just recently on Accelerated Health, and he basically said, look, it was pain and suffering putting all the EMRs in, but now we're starting to get kind of useful dashboards, and we're kind of getting some of the benefit out of the data's coming out, and now we're starting to get there. And we have, COVID in San Francisco has got really good useful dashboards coming out of UCSF elsewhere. So I think you could argue some of this stuff is starting to happen. Grace doesn't approve.
Patients need their own dashboard. Yeah. We need well, first of all, we need access in general. And I'm going to recommend that any company that starts pulling all this stuff, hospitals need to update their patient bill of rights to actually reflect today and the business practices that are happening, because most people don't know what's happening. So I'm extremely frustrated that all those analytics are privy to the vendors and those inside the four walls of medicine, which isn't very transformative for us outside the four walls of medicine. That's it.
I'd agree, but I mean, you hope the infrastructure is slowly getting there, and then the legislation. Robin mentioned the Transparency Act around billing and around hospital charges. We could argue it's slowly getting there, but it's a way away from where it needs to be. But I mean, the bigger question though to me is, so we're the kind of end game of the digital health investment thing is becoming clearer. You can now, because the market's so frothy, you can get out in a SPAC if you're a half decent company. You can get out in a SPAC if you're ready to say that your revenue is going to go from 50 million to 1 billion in 5 years, as Holt did, which may be a tad aggressive. And you can get out, and you can IPO as a loss-making company if you look like you have a good, solid business that's growing fast, like a Signify or for that matter, a Teladoc's done. Whether that's enough to move the needle on the overall system, to me, is the bigger question. And Kim, why don't you say a word or two about what you said about General Motors? Because that, whether or not you believe General Motors is, really believes it's going to become an electric car company and give up on internal combustion engines, but
they're prepared to basically change. They say they're prepared to basically change their entire history and go from internal combustion vehicles to being an all electric, zero emissions in 15 years. And there's no healthcare company that I'm aware of that is making that kind of commitment to totally changing what it is. I want to go back to something Grace said a long time ago that, the thing that a lot of people who do not spend a lot of time thinking about healthcare is that a small percentage of patients account for the vast majority of healthcare spending, and they're going to spend that money every year as long as they're alive. And the question that every society has to figure out is, how are we going to pay for them? We can not worry about them and let them bankrupt themselves. We can raise our taxes. We can try to do it through premiums and then fight about how high our premiums are. But we don't do that very well. We're not very good. We look at our own, how much we pay in our deductibles and our premiums, and we don't think about those 10% of people, because unless they're in your family, you don't have to think about them. And every health insurer for the last 30 years have been trying to figure out how to identify those people, how to spend less money on them. And many of these point solutions that we've been talking about have been efforts to do that. And they've all found that, well, you can save money if you target it very closely, but when you start rolling it out to the entire population, it's a lost leader, it's a lost loser. And I think a lot of these point solutions have not figured that out yet, that going big is not going to work because you only save money on the people that are very sick. A couple of years ago, I wrote that our healthcare system does things on average. On average, it's an okay health system, but the problem is we give way too little to the people that use it a lot, and we give way too much to the people that don't need it very much. And if we were really smart, what we would do would be we would have a healthcare system that devotes every possible resource to those people and making sure they get all the stuff they need and only the stuff they need. And for the rest of us, it should be a lot more like a public health system that tries to address public health problems, of which most of our health issues are public health problems. But that would look like an entirely different health system than what we have now.
Right, well, we won't pick all on Robin just because she is the most expensive person on the call. Even though you're only, what did you say? You're only 15%.
16,000 a year, probably.
If you were at Stanford, right? If you were at Stanford.
It would have been, for my case particularly, I'm now about 16,000 just for my medication called Remicade. But over a 5-year period, I've saved my insurer $1 million now in top line billing by moving it to my home a mile away from Stanford.
So did they cut you a check for a share? I guess not.
Right? They did hire me, and I did come in and give United Healthcare a keynote. So,
Hopefully the keynote, you could pay $900,000 for your keynote, I would hope.
Yeah, well, I should think about doing that next time. But I mean, what he's saying is totally true. We're the ones who use up the vast majority of healthcare and that big spending. And I'm telling you, a lot of it is where you get your healthcare. It's that healthcare delivery and that huge markup that we're seeing in different places. That's why we're seeing Humana and CMS pushing dialysis out of the dialysis units. I mean, John Oliver did a big thing on that a few years ago. And they spend a huge amount of money on dialysis clinics. And by moving it into the home, they can charge significantly less. By bringing everything into the home as much as possible, it is so much cheaper because you don't have that brick and mortar.
Do you see United? And I know you're obviously a very activist patient, but and I've consulted with a couple of startups. I think foolishly one of them I've invested in, which basically were trying to go to employers and doing what some of the travel startups are going. I think there's one called Trip. I forget the name of the company, which probably had a terrible year because there was no business travel. But their basic deal was they went to employers and said, okay, your people are flying around the world and they're staying in hotels and they don't care what they're spending. But here's a way we'll set up a system where you can give them basically a per diem rate. And if they can find the cheap flight and stop over in Cincinnati or wherever it is, or stay in the Motel 6 and not in the Four Seasons, then they get a cut of the difference. And I've seen a couple of approaches to try to do that for the employer side in healthcare, where people have gone to employers and said, companies going to employers and saying, we'll give you, we'll figure out where the cheaper MRI is if you go at 5 o'clock on a Saturday rather than 9 o'clock on a Thursday morning, and you drive another 20 minutes or whatever it is, and we'll give the patient a cut of the difference post the deductible. Obviously, a lot of this stuff usually you fill up your deductible, after that you don't care. Your argument, I think, Robin, would be that to help to solve Kim's problem of scaling it is you have to give that kind of cut down to the individual patient level and get them involved in this. How far do you think?
You are giving them a cut. So when I was getting my Remicade at Stanford, my copay was $1,000, $8,000 a year, and that was after my deductible. Now my copay is something like $100 or like $90. right? And so for me, basically, they are paying me. They're paying me, what, $7,000 a year to move my Remicade into the home where I get to lay in bed and hang out.
I was saying we have tried that. It's called deductibles and coinsurance, and people are rebelling against it because they don't want to pay the deductibles and coinsurance. But all the studies show that when people have to pay preventive care out of their own pockets, they don't get it, even though it's a wise investment for them on their own thing. So we say, okay, we'll make it zero deductible. People they don't get the care that they need to when they got to put their own money out in many cases. I mean,
I know that's a problem, but I mean, I'm wondering, are we getting that? Is there enough support, or will we get more support? You have companies like Accolade and Grand Rounds and others who are doing the kind of navigation and helping get people to presumably better, higher quality care, which obviously is less expensive. You hear a lot about these centers of excellence and people going to the Cleveland Clinic instead of going to their local place and getting a better outcome for less money.
Wasn't that the whole point of reference pricing? Saying that this is how much the stuff should cost, and we'll pay that much. And if you want to go somewhere else, fine, but it's on you. That's what reference pricing is for.
Matthew,
but beyond reference pricing, you're not just. I mean, Robin's smart. I've noticed that $8,000 was more than $100 or whatever. But yeah, sure is. That's that high class education you have, Robin. But I mean, my question is, are we doing enough? You talk about Accolade and Grand Rounds and the other companies who are helping to help people navigate and understand what's going on, because there's still a huge amount of complexity, right? And then when you actually get into a particular episode of care, especially if you're not understanding it, forget the surprise billing and all that other stuff. There's still bills from all over the place. It's still very hard to track what you're doing. And I don't think health plans have done a great job scaling that part. So that's my question.
Michael said it before. Who does the complexity benefit?
Yeah, I mean, I have a general question for all of you who are on the investor side, and that is, has anyone or is anyone gaming out what would be the impact on your investment decisions and on the businesses you become involved in if we actually did switch over to a universal healthcare system? Has anyone gamed that out? And if not, why not? Is it that you believe that is just infinitely impossible, or that were it to happen, it would have no impact on your investment decisions? What would happen if tomorrow we did have Medicare for all to all of your businesses and different types of financial relationships?
Yeah, so I mean, I think anyone who's an investor has to try to look at, economic macro risk and political risk. Mike, I'll try to answer your question as well as answer the question that I didn't get to answer that Matthew asked about the why don't we have a big, bold plan? And I think we just need to all remember we're not even 30 days outside of the Trump administration, and we're just 45 days out from an insurrection, which I guess is not in today's news cycle, so we're not talking about it. But our Capitol was stormed, So no, we're not getting any big sweeping changes. That ain't happening. The president is trying to do unity. Unity means the center. It means trying to find things that both sides can agree on. And universal healthcare ain't a both sides agree on thing, not even close. So, if we actually want the president that we just put in to unify the country, and we believe that is the first order problem that we have, as opposed to getting our particular left-leaning agendas across the line, then no, we're not going to get some super big, broad sweeping plan, and we're not going to get Medicare for all. And I'm not worried about that right now. I'm trying to actually see if we can go 6 months without some massive upending of our society, right? Where there's a militia that storms someplace and threatens to kill a highly, positioned elected official. That's what I'm hoping for. 6 months of that.
Marcus, I'd like to ask an addendum to Mike's question. Have any of these firms gamed out? Let's say that they're wildly successful and our $3.8 trillion healthcare system becomes a $1.9 trillion healthcare system. Is that good or bad for them?
I mean, look, I think that generally speaking, so I'm based in Nashville. where there's a lot of for-profit healthcare services businesses, right? I think generally speaking, the opinion is that we need to, this is going to sound like I'm speaking out both sides of my mouth, that we need to control costs and we need to lower the cost of healthcare, and healthcare is going to take a bigger chunk of GDP over the next 8 years.
My concern about startups for the last several years is that it's not so much that they want to save money, it's that they want to take money from someone else.
Well, look,
I don't have a problem.
Look, try to do anything at scale and not make money. Other than talk on Twitter. You can do that for free. But like to actually do something that's going to move the needle in any way, you need money. Money's a needed thing. And so you have to be clever enough to try to figure out how you can make money to operate and hire really smart people that can actually deliver value. And that means you have to make a business. Now, in healthcare, we can talk about the private market all we want, but there's one clear key player in the healthcare system in America that actually can do things at scale, and that's the United States government. That's it. Right. And so if we wanted to have an entire hour and talk about the policy, that would be useful in talking about how to change healthcare. Talking about the private market is not useful because the private market is playing off of what the public market is incentivizing it to do, period. The only reason why we're starting to see businesses at scale move into value-based care is because we're finally starting to see enough money flow towards value-based care to make it worth doing. But no, HCA and all of the other healthcare services businesses can't stop everything they're doing and go wholesale into this other direction until all of the incentives have been figured out and a transition plan has been put in place. Because, oh, by the way, they employ a bunch of people and they have to care for a bunch of people today, and those changes could bring out a lot of disruption and actually probably cause a lot of people to get sick and die in the transition from one model of care to another model of care. So it's just very, look, I think I am probably politically left-leaning, although I consider myself to be generally centrist because I'm a capitalist, but I'm mostly left-leaning. But I also understand that, the Biden administration received no cooperation right up until they entered the office. And so with less than 30 days on the job, how good can their plan really be? How good could anybody's plan really be, with no cooperation? Is
there one single thing, Marcus, that you would like, if you were in control, that you would like to see done that would be a deal changer by the government?
Yeah, I would like to see bolder initiatives in the direction of cost saving measures. And so I want to be clear to not necessarily just lump it in and say value-based care, because who even can explain to me what value-based care means, but really getting serious about cost saving. That would probably be sort of the first thing I would love to see. Yeah, I think that would be the first thing I would love to see. How do we actually save money? And Grace said to who? I would say to the United States of America, because we all pay into healthcare, right? Everybody who's working, who pays taxes, pays into the United States healthcare system, right? So the most equitable way would be to say, how do we save the country money? How do we lower the cost to the country of delivering care? Because that's something that the people who are in charge actually could do. They're not well positioned to do public health. These are not public health organizations, okay? They've not been incentivized to do that. They don't know how to do that. They don't know how to market. They don't do branding. They don't do communications. It's not what they are. They are fee-for-service organizations who deliver care in that model. So the question is, how can we collectively cut costs? And actually, I think if you introduce them into the equation, they'd actually have some really great ideas.
Do you think you'd have to spend money to save money?
Potentially, but I'm not smart enough to answer that question.
Well, I'd argue that to Mike's question, that you've got some obvious areas where there is sort of monopoly profiting going on, and you can see that sort of the increase in drug pricing, for stuff that's well past the patent. In some cases, the patent should have expired ages ago, but they managed to do with legal gains.
That's easy.
So that's one. You've got the surprise billing. You've got the out of network stuff, which could go. You could do some percentage of Medicare. You've got the really egregious stuff that nobody should be doing, like the excess back surgery and stuff. There's some things you could start working on there. I mean, there are things you could do around pricing and around really bad behavior. You could start
standardized pricing in her geographic region, right? Like a mammogram at Stanford and PAMP costs $850, and at a breast center, which is freestanding clinic, and they're experts in it, it costs $300.
Yeah, so I think some of that stuff, right, and price. So there's some things you could do by fiat, which I don't know, but within the current system. But the bigger piece, right, which is, I know not all startups, Kim, but some are saying we're going to change the way we do these things completely, and we're going to revolutionize primary care, and we're going to do online and offline stuff, and we're going to go around the hospitals, and we're going to change, which is kind of what the piece I've been banging the drum from forever, is that should you actually sort of hollow out the existing incumbent systems that health systems that are the most egregious on the pricing scale. Did you notice I didn't say Sutter Health in the middle of that, Kim? Oh, damn it! But if you could go around and then that is what Amazon did to to Sears and all the other retail stores that I went to, department stores and across a bunch of industries. Now, I'm not saying that they are good and perfect, but and by the way, Walmart, similarly, some years before, certainly lowered the prices for those individual goods and services they were selling, which is a benefit to the United States of America in some respect. You can argue lots of bad stuff happened along the way with that. And, that's, I think, the hope of some of this on the sort of the digital health, change the system, disrupt everyone side. But I think we're a long way away from getting that. And the stuff that Marcus was talking about is, I think, much easier, something that we could do much more easily, and the people in power could have a go at that now. But as Mike will point out to us, even doing that has gores a huge number of oxes who don't want their oxes to be gored, right?
Yeah, sure. And one other thing, just to talk to what Kim brought up earlier, is talking about the infrastructure of America. The reality is, I don't know how we get a decent public health system without spending some money, without some investment, right? I mean, it's no different than infrastructure, right? I don't know how we do this without prioritizing investing in this infrastructure. How else would you do it?
But you have to. I mean, this is Mike's point. Spend money to save money. You get a very good return on public health spending.
Absolutely,
we would have got a damn good return if we'd done a lot more. If we'd done a lot more of that before the pandemic, they'd have got a very good return in Texas if they bothered to actually winterize their power plants.
That's right.
For right now, but agree, this is tough stuff because this is talking about investments you don't see for a long time, and you have got to recapture the money some way down the road, and that does mean somebody's also getting gored. It means
the public health has right now is that.
Go ahead.
Sorry, Mike. Then we have to wrap. Sorry, Mike.
The other problem that public health has now is that there are so many people that are not listening to good public health advice. I mean, Kaiser Health News are keeping track of how many public health officials have been driven out of office because of death threats and other things. I mean, I don't know who wants to go into public health these days because there are so many people that just will refuse any, good public health recommendations.
Mike.
Yeah, I think the way to think about public health is the winterizing analogy. It is a very pragmatic type of business. Now, there are public health officials who are not that way. They are much more like academic physicians who are partway up their own career ladder and who have multiple alliances with a lot of other people that have very little to do with downstream public health. So I think if we were going to actually rebuild the public health system, we'd have to look at both the human side of this as well as the downside system side of things. Both of them need attention.
I agree. I mean, there are so many things that need attention. They're all interconnected, as we said. All right, and with that, we're close to the end of our hour. So I'm going to quickly go around the horn and ask everyone what they're to give us a forecast, a prediction, or what they're looking at for the next couple of weeks. So I will start with you, Grace.
Oh gosh, I hope we see Texas back to, well, I guess before this disaster. I don't want to call it normal, but gosh, let's get those people where they need to be so they're not in the freezing cold, and anyone that's without water and the basic necessities to survive and thrive in a pandemic. And I'm hoping to continue to watch the trends on the cases falling and what the reports and science is going to say that's driving that.
Kim.
I'm waiting to see if Ted Cruz can get back from Cancun and prove to be as equally useless in Texas as he is in Cancun.
Oh, harsh but fair. Marcus.
Much to my chagrin, I think I'm going to be tracking a bunch more SPACs.
Will be too. Mike.
I'd like to suggest that everybody grab a copy of Some of Us, What Racism Costs Everyone and How We Can Prosper Together, which is Heather McKee's argument that racism is a very expensive proposition and undermines the way we care for each other, both within and outside of the healthcare system.
Well, that was a small point to bring up right at the end of a non-trivial topic. Robin.
I'm just keeping my eye on Israel. So because they've gotten a lot of people there vaccinated. So how fast Israel can recover can show us what the rest of the world can do with vaccines.
Very good, very good. Well, I'm looking forward to the next week. I'll be probably looking at some SPACs with Marcus. The one thing I'd be interested in the next week or two, seen a lot of money going to mental health companies, a lot of money going to primary healthcare, and I'm wondering if there's going to be any sort of market movement, maybe on the private sector side, but maybe also from the established systems about something to bring that together. I think one thing we might get out of all of this, given that 35% or 40% of the country is now showing signs of depression, anxiety, or other mental health concerns, is whether we might start to see a real effort to bring those two things together, because having them be separated probably doesn't make a whole lot of sense. Anyway, with that, we have reached the end of another THCB Gang. It's episode 43, the February 18th edition. I want to thank my guests, Kim Bellard from Cincinnati, Grace Cordovano from allegedly New York, but really New Jersey, Robin Farmanfarmaian from Palo Alto, the center of a place you can go to get a vaccine because nobody else wants one. Marcus Whitney from Nashville, the new home of soccer in America, and Mike Magee from I was going to say from Connecticut, but maybe it's from Rhode Island, Berkshire. I don't know.
Connecticut.
We'll be back at the same time, same place next week. So I look forward to hosting another gang there, 1 p.m. Pacific.